Today, we decided to talk to you all about Meloxicam. To understand Meloxicam and what it does, we must first look at the mechanism of action. The mechanism of action is like that of other NSAIDs. It involves the inhibition of the synthesis of prostaglandins, known mediators of inflammation, by inhibition of cyclooxygenase, also known as COX-1 and COX-2. Before we can clearly understand the ways Meloxicam acts as an inhibitor, we must first understand the underlying mechanisms of the inflammatory pathway. In a cell, inflammation is first initiated by physical, chemical, or another type of inflammatory stimuli. These stimuli activate the enzyme phospholipase A2. Phospholipase A2 causes the release of arachidonic acid, a 20-carbon fatty acid, from the cell membrane. The enzyme prostaglandin synthase has cyclooxygenase activity. Prostaglandin synthase converts arachidonic acid to prostaglandin H2. Prostaglandin H2 is then converted by the tissue-specific isomers into a number of different inflammatory mediators that depend on the tissue or cell type. Once a stimuli is identified, the membrane enzyme phospholipase A2 acts on phospholipids. This particular phospholipase specifically catalyzes the release of arachidonic acid from phospholipid molecules. Arachidonic acid is an essential fatty acid which is consumed in small amounts in our regular diets. It is considered an essential fatty acid because it is an absolute requirement for the proper functioning for the human body. Essential fatty acids such as arachidonic acid are polyunsaturated fatty acids and are key components of phospholipids, which are integral components of cell membranes. Arachidonic acid specifically gives rise to a group of important regulatory molecules called eicosanoids. Eicosanoids are synthesized by most tissues and influence numerous metabolic activities, including platelet aggregation, blood clotting as we know it, inflammation, hemorrhages, vasoconstriction and vasodilation, blood pressure, and proper immune function. Most importantly, their actions are linked to the defense against damage and pathogens. All of the eicosanoids are regulatory molecules that tend to act locally as paracrines. This is because they are degraded too rapidly to move about the body through the circulatory system. The arachidonic acid released from the phospholipid is now the substrate for one of two enzymes. The enzyme that we are most concerned with is cyclooxygenase, also known as COX-1 and COX-2. The product of this reaction then proceeds through a further sequence of enzymatic reactions to produce a regulatory molecule known as prostaglandin. Prostaglandins are part of the class of substances called eicosanoids that we just talked about. Cyclooxygenase is an enzyme that catalyzes the conversion of arachidonic acid to one of several possible endoperoxides. The endoperoxides undergo further modifications to form prostaglandins and other hormones. There are two main types of cyclooxygenase enzymes that we are concerned with, COX-1 and COX-2. COX-1 is found in most tissues and is present at all times. COX-2 is typically undetectable in most tissues and is only produced in response to inflammation. COX enzymes play a role in propagating an inflammatory reaction through the production of prostaglandins. COX-1 also plays an important role in gastric mucosal integrity, platelet aggregation, and kidney function. Due to the importance of COX-1, NSAID use has been associated with cardiovascular, renal, and gastrointestinal complications. Prostaglandins are hormones that control several processes throughout the body, especially as it relates to healing mechanisms. When tissue is damaged or infected, this group of hormones will create the reactions that cause pain, fever, and inflammation, which sparks the healing process. Prostaglandins are very short-lived and are broken down quickly by the body. They only carry out their actions in the immediate vicinity of where they are produced. This helps to regulate and limit their actions. The structural differences between prostaglandins account for their different biological activities. Some prostaglandins act in an autocrine fashion, stimulating reactions in the same tissue in which they are synthesized, and others act in a paracrine fashion, which means they are stimulating reactions in local tissues near where they are synthesized. In addition, a given prostaglandin may have different or even opposite effects in different tissues. The ability of the same prostaglandin to stimulate a reaction in one tissue and inhibit the same reaction in another tissue is determined by the type of receptor to which the prostaglandin binds to. As you can see in the picture, at least 8 different prostaglandin receptors have been discovered. The presence of these receptors in different organs throughout the body allows the different actions of each prostaglandin to be carried out depending on which receptor they interact with. The chemical reaction that makes the prostaglandins involves several steps. The first step is carried out by cyclooxygenase. When the body is functioning normally, baseline levels of prostaglandins are produced by the action of COX-1. When the body is injured or inflammation occurs in any area of the body, COX-2 is activated and produces extra prostaglandins, which helps the body to respond to the injury. Inflammation in the tissues occurs in response to the injury. The damaged cells release prostaglandins as well as other chemicals, including histamine and bradykinin, that we have talked about previously in the semester. Inflammation is a process characterized by redness, heat, pain, and swelling. The changes associated with inflammation are due to dilation of local blood vessels that permits increased blood flow to the affected area. The blood vessels also become more permeable, leading to the escape of white blood cells, also called leukocytes, from the blood into the inflamed tissues. Thus, drugs that inhibit prostaglandin synthesis are effective in suppressing inflammation. This is why, in patients with inflammatory but non-infectious diseases such as rheumatoid arthritis and osteoporosis, Meloxicam is used to inhibit chronic inflammation.
Meloxicam is indicated for the relief of signs and symptoms of osteoarthritis, rheumatoid arthritis, and juvenile rheumatoid arthritis. Osteoarthritis is a type of arthritis caused by inflammation, breakdown, and eventual loss of cartilage in the joints, also known as degenerative arthritis. Rheumatoid arthritis is a disease in which the body's immune system attacks its own joints. It results in pain, swelling, and potentially permanent damage. Juvenile rheumatoid arthritis is an umbrella term under which several forms of chronic arthritis in children are categorized. Regardless of the type, all of these conditions have several historical and/or clinical characteristics in common. Drugs such as meloxicam that inhibit prostaglandin synthesis are effective in suppressing inflammation in patients with inflammatory but non-infectious diseases such as rheumatoid arthritis and osteoarthritis. The efficacy of meloxicam in treating the symptoms of osteoarthritis and rheumatoid arthritis has been confirmed in several clinical studies. 2 clinical studies that lasted 6 months were performed in patients with osteoarthritis of the hip or knee. In the first study, the efficacy of meloxicam 15 mg and piroxicam 20 mg were found to be comparable. One daily dosage of meloxicam 7.5 mg and 15 mg showed a consistently more efficacious response than placebo in a 12-week trial. Both doses of meloxicam were also shown to be comparable to diclofenac 15 mg with regard to efficacy, with a lower incidence of GI adverse events when compared to diclofenac. 2 large-scale randomized active control clinical studies of 4 weeks duration were conducted in patients with osteoarthritis in the hand, hip, knee, or spine. In the first study, the effects of meloxicam 7.5 mg were compared against the effects of diclofenac 100 mg. In the second study, the effects of meloxicam 7.5 mg were compared against the effects of piroxicam 20 mg. The results from both studies indicated that meloxicam 7.5 mg was as efficacious as diclofenac 100 mg SR and piroxicam 20 mg in the treatment of symptomatic osteoarthritis. The use of MOIC for the symptomatic treatment of rheumatoid arthritis was elevated in a double-blind controlled trial for 12 weeks. Meloxicam 7.5 mg, 15 mg, and 22.5 mg daily was compared to placebo, with diclofenac 75 mg twice daily compared to the placebo to establish trial sensitivity. For all primary endpoints, the meloxicam group was significantly better than the placebo for both mean on trial and last observation. A second trial also investigated the use of MOIC for the symptomatic treatment of rheumatoid arthritis. This double-blind placebo-controlled trial used 3 doses of meloxicam, 7.5 mg, 15 mg, and 22.5 mg daily. In the patients with rheumatoid arthritis over a 12-week period, for this parameter, all 3 doses of meloxicam were more effective than the placebo for the duration of the study.
Use the lowest effective dose for the shortest duration consistent with individual patient treatment goals. After observing the response to initial therapy with Mobic, the dose can be adjusted to suit the patient's needs. For osteoarthritis and rheumatoid arthritis relief, the recommended starting and oral dose is 7.5 milligrams once daily, and some patients may receive additional benefit by increasing the dose to 15 milligrams once daily. For juvenile rheumatoid arthritis relief, the recommended oral dose is 7.5 milligrams once daily in children who weigh 60 or more kilograms, and clinical trials prove no additional benefit demonstrated by increasing the dose above 7.5 milligrams. The following patients should refrain from taking Mobic: those with known hypersensitivity to meloxicam or any components of meloxicam. Hypersensitivity can include anaphylactic and serious skin reactions. Patients with a history of asthma, hives, or other allergic reactions after taking other NSAIDs. And those in the setting of coronary artery bypass graft surgery.
Some risks to be aware of when taking meloxicam include cardiovascular thrombotic events and gastrointestinal bleeding, ulceration, and perforation. Non-steroidal anti-inflammatory drugs cause an increased risk of serious cardiovascular thrombotic events, including myocardial infarction and stroke, which can be fatal. This risk may occur early in treatment and may increase with duration of use. NSAIDs cause an increased risk of serious gastrointestinal adverse events, including bleeding, ulceration, and perforation of the stomach or intestines, which can be fatal. These events can occur at any time during use and without warning symptoms. Elderly patients and patients with a prior history of peptic ulcer disease and/or GI bleeding are at a greater risk for serious GI events. Common side effects include stomach upset, nausea, drowsiness, diarrhea, bloating, gas, dizziness, nervousness, headache, runny or stuffy nose, sore throat, and skin rash.